So this is HoLEP part 2. So we're going to go over morcellation and complications on this talk. My disclosures have not changed. So in order to actively morcellate tissue with the HoLEP, you need a 5 French working channel to accommodate the blades. So if you see on Twitter like these 22 French scopes with HoLEP, in the United States, you would have to switch out to another scope to morcellate because you need that 5 French working channel. And for the blades to actually work, you need an offset nephroscope too. So you're switching from a rod lens system to a fiber optic slash rod lens. So your visualization decreases. You need as much inflow as possible. The morcellator is your outflow, and you need meticulous hemostasis before you start. So this is the morcellator that I grew up on. This is where I did my first 1,000 HoLEPs was with the luminous morcellator. We've now upgraded to the Wolf Morsellator, which is much more effective that you see in this video. But you can see when I'm morcellating, there's no bleeding. It's very clear. I'll bring the tissue down into the fossa so that I'm not going to have a bladder injury once the tissue gets small enough. And it stays on the blades better too if you pull it back into the fossa. In this other video, I'm showing how I transition from the laser scope to the morcellator, and I'm putting 2 inflows on. If you learn one thing today, it's that you need 2 fluid inflows, no outflow. The morcellator is your outflow. So what do you do with these beach balls? So most of the time when you morcellate, it's nice, it's quick, it's efficient, but occasionally those of you that's done this, you'll get these hard round nodules that will not morcellate. So there's a couple things you can do. You can put a Foley in, bring them back in a day or 2, it'll soften up. You can morcellate it. Or you can switch back to the laser, cut grooves into that nodule, and then give something for the teeth to grab onto, pull it back into the fossa, and then just be really patient, and eventually it'll morcellate. 9 times out of 10, cutting the grooves will make it so that you can morcellate more easily and get those beach balls out. I think that's the most common question I get is, "What do you do with a beach ball?" And this is how you manage it. You can also try switching out the blades. Sometimes that will help, to get a fresh set to morcellate the tissue. But with the newer morcellator, this is not that common. Um, s- some people think, well, if you morcellate the tissue, you can't check for cancer, and that's absolutely not true. So there's been a very old study from 2004 where they looked at the tissue distortion with morcellation and compared it to TURP, and they actually had a comparable rate of cancer detection. You don't get that charring effect, so you actually have a little better look at the actual individual cells with the HoLEP as opposed to a TURP, but it's very comparable. And about 8 to 12% of the time, depending on the series, you're going to find cancer in the specimen. The vast majority of the time, it's low grade prostate cancer if you've done your workup appropriately. So now we're going to go over complications. We think about this in multiple groups: intra-op, long term, and then I'm going to go over some unique situations if we get to that point. So, intraoperative complications, everyone worries about this, but they're actually quite rare. They include capsular perforation, bladder injury, fluid absorption, and ureteral orifice injury. The nice thing about working at an academic center is we have these systems that record everything you do. So you can find these interesting problems. And this was many, many years ago. A fellow of mine was doing a case and he thought he was going into the bladder, but he actually went up over the bladder and perforated the capsule, like you see here. Um, and so, what do you do with that? You really don't have to do a whole lot different. I just came back in, did a top down technique, found the correct plane, and then we left the catheter in a little bit longer. Perforations are really related to skill level. So they range from zero point 0.6 in what we consider a master surgeon to 10% in people who are learning. The vast majority of the time, it doesn't change your management. So if it's less than 20% of the capsule, you can still get the catheter out the next day. But if you're having a large volume perforation like the one shown here, you're going to leave that catheter in a little bit longer, let that heal, because you don't want to have urine leak, fill up the scrotum, or leak into the retroperitoneum and cause issues. But it will heal, especially if they've not been irradiated or had a PAE. They'll heal within a few days. Bladder injury, probably the most worried about complication. I get asked about this all the time, and it's actually, again, quite uncommon. Most of them are superficial and do not alter your treatment. So if you think about a bladder biopsy, you know, this is very similar to that. Significant injuries are extremely rare, and generally you just manage this with a catheter. Most of them are retroperitoneal. If it's intraperitoneal, obviously involving the dome, or if you have a lot of tissue left to morcellate, then you just need to open the patient, fix the injury, and take the adenoma out. So most of us will morcellate in the fossa. To ensure that you don't have an injury, you want to have complete hemostasis so you can monitor the bladder as you're morcellating. You must have that bladder over distended. So you want the two inflows to make sure that you don't suction it into the blades and make sure the tissue is actively engaged into the blades before you activate the blades. So again, that nice Artemis system that captures all the images. This is a bladder injury. So we had a nurse change. The new nurses said, you don't need 3 bags running. Clicked off 2, only had 1 bag running, and it suctioned down into the blade. Number 1, don't panic. So you detach the suction externally from the handle, and then you can disassemble the blades from the handle. And when you do that, you can see that this injury is extremely superficial. So we just put the laser back in. There's no muscle. It's very superficial, and you just cauterize the edges so it doesn't bleed. And this patient's pathway did not change. But the only reason it didn't change is that we recognized it early, didn't panic, because if the fellow had popped that back into the scope, that would have been a full biopsy of the bladder. The other potential things that can occur is fluid absorption. So you can actually get quite a bit of fluid absorbed during a HoLEP, and they've done alcohol labeled studies where they label the fluid with alcohol and then do breathalyzer tests of the patients during the case. And they found that you can absorb anywhere from 200 cc's to 1,000 cc's of fluid during a HoLEP procedure. So if the surgery is going to be longer than an hour, I usually give 20 milligrams of Lasix at the end of the case just to diurese off any extra fluid absorption. I was very fortunate when I was at Mayo to be involved in a case of severe metabolic acidosis. The patient stayed in the hospital overnight. He went to ICU, and then it resolved with just intubation. So he blew off the acidosis. But the problem with that is that he had a large prostate. We had that old morcellator that took hours to morcellate, and he had some open venous sinuses. Nowadays, we have much better hemostasis. Morcellation's much faster, and we rarely, if ever, see that. Ureteral orifice injuries are also extremely rare. You would think it would be more problematic than it is, but it's usually between 0 to 2% of cases. It's when you're trying to get that large median lobe out. So that's why we do those cuts from lateral to medial, so that we can ensure that we're not going to laser a UO when we release it from the bladder neck. When we talk about the immediate postoperative period, of course, bleeding is always a concern, but we also talk about incontinence and infection and need for recatheterization. So return to the OR again is related to equipment used and technique is between 0 to 6% of cases. Clot retention is around 3% of cases. Transfusion rates are between 0 to 2%. They can be as high as 8 to 13% in the anticoagulated patients. And the way you really avoid these bleeding events is to be in perfect plane. So some people, when they're starting out, they're very worried about getting too deep, so they leave a lot of tissue. That tissue will not coapt and it will not stop bleeding. It's very hard to stop it with a laser. But if you're in perfect plane and you see the actual vessels, that's very easy to stop. Conversely, if you get too deep and you get into those venous sinuses, the laser won't stop that either. So you need to be in perfect plane. Need for recatheterization is actually really uncommon, and that's why I love HoLEP. If you can deobstruct them, even if patients have a weak bladder, most of them will be able to urinate. But right in the immediate postoperative period, about 10 to 12% of people just can't urinate. So you have to recatheterize them, wait a day or two, and then try again. But usually that second void is the key for them. Infection, just like any other endourologic procedure, is a possibility, and it occurs about 0 to 6.7% of cases. I've seen patients get significant epididymitis, UTIs. I have personally not seen a sepsis case, but that's because I give AMP and GENT intra-op, and I think that covers the whole spectrum. And then I give a week of antibiotics before and after surgery if they've had a catheter, if they self-cath, or if their urine culture is positive. Everybody gets a urine culture. But definitely sepsis is a possibility. And then you have the long-term complications. We already heard an excellent talk on bladder neck contractures. That occurs in about 0 to 3% of cases. Usually it's the smaller prostates, that less than 50-gram prostate that you're doing a HoLEP on. I personally do a releasing incision at 3 and 9 if it's a smaller prostate after I've done the enucleation and the morcellation, just to let that bladder neck spring open. And when we looked at our data at Northwestern, it's less than 1% to have a bladder neck contracture. And I think those incisions help. Urethral stricture rate, again, it's having a loose urethra around your scope. So if it's going to be really tight, you either need to dilate it more or drop to a smaller size scope to decrease that. The nice thing about a laser is that you don't have a bleeding current like we had with old-fashioned monopolar TURP. So it does have a lower stricture rate than the old-fashioned monopolar TURP at around 2%. I think HoLEP really shines when we can use it after failed prior procedures. So I think I can make a whole business on just retreating patients who failed something else. I do it after TURP, green light, Urolift, PAE, aqua ablation, resume, tuna, microwave. Tuna is actually the worst one. You don't see a lot of those patients rolling around, but there's something about how they would drop those needles deep down near the capsule and then do the ablation that really obliterates that plane. So it's very difficult to treat those patients. But the rest of them are all actually quite straightforward. And we found that when we treat patients who have had a prior surgical procedure and compare them to patients who didn't have a prior surgical procedure, they can have the same excellent outcomes. There's really no difference in the groups with their long-term outcomes. Urinary incontinence. So, urinary incontinence is what everyone fears the most, and it's actually very common right after surgery. I tell my patients about 30% of you will have some temporary leakage right after the procedure. It's often associated with urge, but these men with these 200-gram prostates have never used these muscles. Like they've been relying on their prostate for their continence, and now I'm going to take that out and they have to retrain their pelvic floor. So I counsel all my patients about temporary incontinence and then realize that about 1 to 2% will actually have any form of any type of incontinence long term. Pure stress incontinence is actually quite rare with our current surgical techniques, but I give everyone pelvic floor physical training, like we were shown earlier, to overcome those urge components and to strengthen those muscles. So, one study that came out of Canada looked at specifically just incontinence, and they found that stress urinary incontinence was around 7 to 12% of their patient cohort. And it was more predominant in men who had diabetes, had large volumes resection, or had massive PSA reduction, which is what you would think, right? These are patients whose pelvic floors have probably not been used for a while and they're not that strong. But there are some things we can do to help with continence. And if you think about this, the pelvic floor actually runs over the surface of the prostate. And so the vast majority of that sphincter muscle or pelvic floor muscle is on the anterior surface, and then it wraps around posteriorly. So when I showed those surgical videos earlier, where I'm trying to push forward as I cut that urothelial strip, that's so that I can leave as much urothelium as possible at that 12 o'clock position near the sphincter so that I'm not transmitting any energy or force on the sphincter. The depth of penetration of the holmium laser is about a half a millimeter. So I really have to be pushing on that tissue and lasering to hurt those muscles. I think a lot of the incontinence actually comes from blunt trauma and force. So that's why I rely more on the lasering and less on that forceful manipulation. But when we started looking at our incontinence data, we found that 16% of men actually are incontinent before the surgery. They're wearing pads, they're wearing diapers because they have such severe urge incontinence that they've allowed this overactive bladder to go on for so long. So we're trying to correct that with our procedure. And so these patients all funnel to me because nobody wants to deal with this. They've got an enlarged prostate and they have an overactive bladder. So we started actually trying to combine Botox injection at the time of the HoLEP to get them through that tough post-op period. So we had 82 patients with baseline urge incontinence, and 41 of those patients received intraoperative Botox injections. The original trial was 200. We've now only do 100. But in this trial, we did 200. And then we had 41 controlled match patients. And we found that there was no increased risk of failed trial avoiding. There was no increased risk of post-op urinary retention. But their immediate post-op continence scores were significantly better in the men who got the Botox than the men who didn't. And all of these men had incontinence before the surgery. So it definitely helps in that difficult group. Um, with a caveat, we do not do the Botox injection if their post-void residual is over 150. So they have to have that predominantly overactive component. So things to do to minimize incontinence, obviously treat the overactive bladder. Some people say using a smaller scope versus a larger scope, or use this type of laser or that type of laser. But I think it's just operative time and experience. The shorter the surgery, the better the plane, the better your outcome. And then trying to spare that anatomic strip anteriorly. Now I want to pivot to erectile dysfunction. So a lot of people have this misnomer that if they get a BPH procedure, they're not going to be able to have erections, and that's just not true. Multiple studies have looked at IIEF5, IIEF6 scores before and after HoLEP, and there's absolutely no change. However, they will develop retrograde ejaculation, and explaining to men the difference between retrograde ejaculation and orgasm, I do that all day long in my clinic because I think most people don't know the difference. And so I'm going to actually do a podcast on that so I don't have to say it every day. No, I don't know. Finally, I just want to go over just a couple of unique situations. Because we're using holmium laser, it's really, and I'm an endourologist, it's very easy for me to treat the patient's stone disease at the time of surgery. So this one's what we would call a grand slam. This patient got a left perk, right ureteroscopy, cystolithalopaxy, and HoLEP all in one setting. And we looked at our patients who get this done, and we found that we had 188 patients who underwent whole and concurrent surgery, and 16% underwent at least two surgeries. And we found that we're still able, with our post-op same-day discharge pathway, to get these patients out who had multiple procedures in less than 4 hours in the hospital. So it's a huge cost savings. I also like to use HoLEP for prostate abscesses. This is the best way to get rid of an abscess. The plane is still there, and you're not running the risk of actually leaving a pocket behind. So you do the same enucleation that you would have before, and you work in that plane, and then you can get all the pus out. I just really like this video because there's pus. So and finally, I want to conclude a little bit on prostate cancer. So we can do HoLEP in patients who have had prostate cancer, low grade or high grade. It doesn't really matter. The plane is almost invariably still there and they can still have a good result. It doesn't increase spread or accelerate the cancer. However, sometimes in the higher grade cancers, identification of the plane can be spotty. So if it's invading the trigone or the rectum, you don't want to touch that case. But if you have a clear plane on the MRI between the rectum and ureteral orifices, it's definitely doable. Um, Sometimes we do find prostate cancer in the specimen, and the majority of those are low grade, and we just manage with active surveillance. However, if you do find an actual prostate cancer that's significant that you somehow missed, it's good to know that you can actually treat them with whatever you want. If you have a good surgeon that can do a radical prostatectomy and have a similar outcome as someone who had a prior TURP or open prostatectomy who gets a robotic radical prostatectomy. It's not going to be easy. It's more technically difficult for that surgeon, but they can still have continence and even have a nerve sparing procedure. So, in conclusion, HoLEP is associated with few complications: bladder injury, ureteral injury, capsular perforation, fluid absorption. We think about incontinence and clot retention and infections and strictures and bladder neck contractures, but it's very similar to any other surgical procedure, and you can have those great outcomes. So, thank you.